Hi, I'm Stacy Christensen. I'm a board-certified physical therapist in neurologic physical therapy. I'm going to talk to you today about mobility assessment and treatment in individuals post-stroke in the post-acute care setting. Today we're going to talk a little bit about some of the common sequelae after stroke, a few of the select components of a post-stroke evaluation. We'll go into a little bit of information on evidence-based interventions, and then talk briefly about discharge planning in the post-acute setting. So as you can see here, these are some of the common stroke sequelae that you might see in an individual post-stroke. You might or may not see all of these specific characteristics, but some common things to keep in mind when you're doing your initial assessment that you might not see in another diagnosis. So first we're going to talk a little bit about the differences in stroke presentation depending on the hemisphere that's affected by the stroke. We'll look at the left hemisphere, and if that's where it occurs, you're going to see impairments with hemiparesis and sensory loss on the contralateral side. But you're also likely going to see speech and language impairments and slow and cautious behavior, because individuals with a stroke in this hemisphere tend to be more aware of their impairments and therefore slow down a little bit and are a little bit more guarded in their interactions. It's also common to see memory impairments and likely apraxia. Whereas if the stroke occurs in the right hemisphere, again, we're going to see paralysis and sensory loss likely to occur on the left side. But in this hemisphere, we're more likely to see visual or visual spatial impairments and individuals who are more quick and impulsive, because they tend to have a little bit less insight into their impairments, and so they move a little bit more quickly. You're also going to see memory, but you're more likely to see neglect or inattention if the stroke occurs in the right hemisphere. So having a nice understanding of which hemisphere is affected and which behaviors they might present with an impairment on this side can be helpful as you structure your assessment. The next thing I'd like to talk about is the difference in the circulation. And so we'll talk a little bit about that on the next slide, but you can tell that based on which cerebral artery is affected, you might see some different impairments. So if the stroke is in the middle cerebral artery, that's the largest artery in the circulation, and so it's going to be the most common location for a stroke. And because it's so large, it's also going to have effects in almost every lobe of the brain because of the distribution, and so you can see a lot of different effects. And you're more likely to see impairments in the upper extremity compared to the lower extremity if you're in the middle cerebral artery. Now, if you're in the anterior or the posterior cerebral, they both have some collateral circulation, and so potentially you'll see fewer impairments in this area because you have the ability for that type of circulation, which may or may not minimize your deficits. But in the anterior cerebral artery, you're likely to see more lower extremity impairments than upper extremity. And in the posterior cerebral artery, it's more likely to affect your vision and memory. So again, just understanding how the location of the stroke can make a big difference in what you would expect to see when you're doing your initial assessment. So if you look at the sensory homunculus that most of us are familiar with by now, and then you overlay the general distribution of the cerebral circulation, you can start to appreciate why where the stroke is can matter. So that giant middle cerebral artery distribution is more likely to give you impairments in these areas compared to the anterior cerebral artery. So having a nice appreciation for that can help you to begin to hypothesize what impairments you might find on your initial assessment and begin to prioritize your tests and measures in that way. Your initial assessment in this setting, in the post-acute care setting, is not likely to look a lot different than in any other setting. You're still going to do your chart review to gain all the information about their past medical history, their surgeries, where they've been in their hospital stay and what interventions they've had, as well as the patient and family interview to learn a lot about your patient and what matters to them and what their goals are. That's not a lot different than any other setting, other than really beginning to appreciate what changes they've already had since their stroke. Are they continuing to improve? Are they already improving? Or are they kind of staying about the same? Again, that can start to guide what you would expect to find during your assessment. The objective assessment is also not a lot different in that we're always looking at strength and sensation, how people are able to do individual things. But in this, I want to highlight a little bit, we're going to screen for cognition and orientation, as that can be impacted by stroke. So taking a moment to really see how they're doing with those areas. We're going to screen to test. As we all know, the time to complete an evaluation is relatively limited and we can't test everything. So figuring out what we need to specifically test by doing a screen first, especially in some of the sensory and motor modalities, can be extremely helpful. And then as always, in the world of physical therapy, we really focus on mobility. And so we want to do a really nice job of assessing all of their mobility, their posture, and the list can go on and on. So we'll get a little bit more into the details about what we want to look at. But I want to talk about how to prioritize some of that information. So using the chart review, using the interview you did with the patient or the family members, and sometimes your imaging, you want to take a moment to screen for some of those things we've already talked about. So are they alert and oriented? Do they know where they're at and what's happening? And how's their memory? Because if those things are impaired, you're going to have to start to adapt your assessment in how you're asking questions and how you're structuring things in order to be able to get the most out of the session. Second, we want to look at sensory, because if their sensory modalities are impaired or they don't have great proprioception or light touch sensation, it can start to affect the way they do other movements. So it will look like other impairments when it might simply be a sensory limitation. We always want to pay attention to language and swallowing. Do they understand what you're saying to them? Can they express their wants and needs to you? And are they swallowing okay? Because if not, we need to make sure we're making appropriate referrals outside of physical therapy. And again, adjusting our method of communication so that they understand what we're saying. And then finally, the motor and functional ability. I know that that's last, but it is kind of the bread and butter of what we do. But understanding these other things first will really help us to adapt our assessment in a way that gathers the most meaningful information. So talking about those sensory modalities, we all know the three main sensory systems. We're going to focus a lot on light touch and proprioception. You don't have to do a formal assessment on everyone, but doing a nice quick screen to see if their light touch and proprioception are intact, it can give you a lot of information as you go forward in your exam. One thing I'd like you to be aware of is something called extinction. So when you're testing light touch, make sure that you're testing only one side at a time. So test the uninvolved side first and then the involved side, because if you test both at the same time for light touch, they might only be able to perceive input from one side at a time. And so it appears as though they have impaired sensation on their impaired side, when truly it's just a matter of the brain is unable to process information from both sides concurrently. So when testing light touch, be sure to test the sound side and then the affected side separately. Vestibular really only needs to be screened if you suspect there's an issue, if they took a fall or they're demonstrating something else that looks like a vestibular impairment. But we should be looking at vision. Impaired vision can have a pretty significant impact on prognostication and how they're doing. And so if we suspect vision is involved, doing some simple vision screens such as the H test or having them do saccades and looking back and forth between your fingers, screening those visual fields by coming in from behind just to be sure that their vision is intact, that they've got adequate ocular motor movement, can help you have a better appreciation for whether or not their vision is going to impact their mobility. Now, to talk about perception, this is something that we as physical therapists tend to do simply by observation, watching our patients. Are they attending to that affected side or not? Are they noticing that their arm or their leg are hanging in a funny position? Or are they simply unaware of the impairments in the simulation to that side? It's not related to a sensory impairment. It's really related to their body's ability to perceive that something is occurring on that side. And it's really just paying attention and observing how your patient is moving and then incorporating that into your therapy sessions and again, referring that out to occupational and speech therapy as needed. I want to spend a moment and talk about something called controversive pushing or ipsilateral pushing, or what used to be called pusher syndrome. And this is a visual spatial disorientation in which the individual perceives upright as about 20 degrees to the side of the impaired side. Now, typically after a stroke, someone will lean toward their sound side. It's safer over there, right? They can feel everything, and so they tend to lean toward their safe side. Now, if they are using their sound arm and leg to actively push themselves through abduction and extension toward their more affected side, that's called controversive pushing. It is a perceptual impairment, and there are actual outcome measures to help you test it. So if you think your patient might be demonstrating this, a couple of those do exist, and I would encourage you to dig in a little bit more. I do want you to recognize that individuals with controversive pushing feel at home 20 degrees to the side. So if you try to push them back up to neutral, they're going to feel like you're pushing them over and they're going to push harder. So interacting with these individuals take a little bit of a different touch and something that you should definitely be screening for and aware of. I could talk about that for a very long time, so if you interact with an individual with pusher syndrome, I encourage you to dig in a little bit deeper. And then we get to the motor assessment. This is what we really do, and it could go on for a very long time. And so we start this with just a gross motor screen, right? Can you raise your arm up above your head? Can you bring your knee to your chest? That starts to give us a little bit of an idea of whether or not they can activate volitional movement in that side, or if it's still got some flaccidity following the stroke. And then we have to decide if they can elicit some volitional movement, can they begin to isolate gross movements? So can they only move in one big movement that we call a synergy, or can they move one muscle group individually? And there are some tests like the Fugelmeyer or the Stream that can help you kind of tease some of that information out, but it gives us an idea of how much they're able to move and how much of it they can do volitionally versus how much their body's determining how they move. Individuals with stroke do not typically present with true muscle weakness, especially in the acute and early subacute phase. It's more an impairment in motor control. They can't get the muscles to turn on when they want them to turn on, and so often a standard manual muscle test isn't going to give you the information you want. Someone might be able to stand up and turn their quad on to do a functional movement, so you know they have some quad strength, but when you ask them to kick their foot out for a manual muscle test, they can't do it. That doesn't mean they have a 0 out of 5 quad strength. It means they have impaired motor control. So in this case, be sure you're using functional movement in your clinical judgment to make an assessment of their functional strength, rather than relying on just a manual muscle test. Other common impairments include tone and spasticity, which may occur together or not. Tone, as we know, is simply resistance to passive movement. It's just an increased tone in a resting position. That is hypertonia. There's also low tone, which tends to occur right after the stroke and then can increase over time. And so just passively moving the limb to see if they have a change in their tone, versus spasticity, where we're really assessing the resistance to a velocity-dependent movement. So if you quickly move one single muscle through a range of motion and seeing if you get an increase in resistance. That spasticity or increase or decrease in tone can really affect how someone is moving, and understanding if their movement limitations are related to one of these two things rather than a weakness pattern can be useful as you're trying to figure out how to help someone move. The modified Ashworth scale is the gold standard for assessing spasticity. Coordination, something we all know and love and have probably gotten really good at testing over the years, but do keep in mind we can assess gross or fine motor. Our occupational therapy friends are probably doing a lot of the fine motor work, but sometimes I'll just do a really quick screen of their ability to do a fine motor task. But you can see a laundry list of some of the gross motor screens that we do here, keeping in mind that we should either time them, one side versus the other, or compare just movement quality between the two. Do keep in mind with any of these assessments that if your patient has attention or cognition impairments, you need to be doing all of these in a quiet, well-lit room where they can really focus on the task at hand. Okay, the mobility movement piece. This is what we all like to do. This is why we became physical therapists. So bed mobility, and this is all of the bed mobility, right? Not just getting up out of bed, but can they roll over? Can they do a bridge? So if they're getting dressed in bed, they can pull their pants up. Can they scoot side to side or up in the bed to reposition themselves? All of the laundry list of transfers we need to know. Are they able to do those things and how? Then it goes on to locomotion. And so that's not just walking, but wheelchair, right? Which mode of locomotion are they going to use? Are they going to be ambulatory? Are they going to need to rely on a wheelchair? Maybe a little bit of both for a while. So we need to assess that. How far can they go? What device are they needing? Do they need assist? Does the surface or the environment that they are in make a difference in how they can do those things? And then sitting and standing balance. Again, you can see a whole lot of different ways to assess balance, and we'll talk a little bit more about some of those outcome measures here in a moment. But getting a good idea of how your patient moves. Now, I'm going to draw your attention down here to this piece at the bottom. Anyone who works in the post-acute setting knows that there are a number of assessments that we have to do when someone admits to a post-acute facility and when they leave. All of those things are already something that we need to know how they're doing. So capitalize on the fact that you have to gather that information, assess how they're doing when they do those movements, because that's going to tell you a lot about how your patient's moving, doing something you already need to do. Postural alignment, or just how they sit or stand when you ask them to get into a position, can be affected by a number of things. Often it's assumed that if someone has impaired posture after stroke, that it's a result of the stroke, but it can be any number of things. Sometimes it's that they've had that posture for the past 20 years, right? Maybe they've got kyphosis with forward head and you keep telling them to stand up straight. If they haven't stood up straight in 20 years, that probably doesn't need to be the priority of your interventions. So keeping in mind what different things might be causing some of these postural impairments, because it might be perceptual, sensory motor, or just that something hurts and they're trying to get away from it. So especially if your patient can't communicate well, keep in mind that we might need to see which one of those things might be causing some of the things that you're seeing. And then finally, when we talk a little bit about balance or dynamic postural control, there are a number of measures out there to test these things. Some of them are for static, some test proactive balance, some test reactive balance, and some of them test everything. So when you're selecting an outcome measure, make sure you pick one that actually tests what you want it to test, and use a little bit of clinical reasoning when you're picking one of those, so you're not just doing something to get it done, but rather finding a meaningful test that gets at the information you want to know. Speaking of outcome measures, a number of years ago, the American Physical Therapy Association's Neurologic Academy released a clinical practice guideline that talks about the use of outcome measures in individuals with any neurologic condition. So that includes stroke. And their goal was to find a set of measures that can be used in any patient with a neurologic condition across all practice patterns that makes it easier for us as clinicians to communicate and track progress over time. And so they came up with this list of 6 measures that will help us to track our patients in any of these different areas. So whether it's static or dynamic balance, gait, speed or distance, their own balance, confidence, or transfers, they gave us these list of tools that we can pick from. Every one of them takes less than 20 minutes. They're all free, and they all involve equipment that you should have in an everyday clinic. Most of them have been around for a while, and we're all pretty familiar with them. So I would encourage you to take a look at these assessments, and when you're picking one for your client, see if one of these is a good fit, and hopefully it was done in the setting before you and potentially can be done in the setting after you, so we can continue to paint a nice picture of our patient's progress over time. I do want to direct you to a place called the Shirley Ryan Ability Lab, or sralab.org, where you can go to and find all the information you need on all of these measures and many, many more, including normative data and how to set the station up and all of those different pieces of information that we need to know when we do something new. So if you're not familiar with one of these tests and you want to do it, go to sralab.org. Those aren't the only measures that we can use, however. There is more measures that I could possibly fit on a slide. But here's a list of a few that might be useful for a patient who's had a stroke when one of those other 6 measures that we talked about aren't quite the best fit. For example, the PASS test, or the Postural Assessment Scale for Stroke. That test includes a lot of items that are already required for you to test for admission and discharge. And so by doing that assessment, sometimes you can get double the bang for your buck. You get a standardized outcome measure, you get testing that you already need to do, and it'll give you some data that can help you determine if your patient might be ambulatory after stroke. The FIST and the Trunk Impairment Scale are both tests that can be done for an individual in a sitting position if there's someone at a lower level and you might need some sort of an outcome measure to track their progress, but they're not able to do some of those higher level tests yet. Either of those might be useful. The Stroke Impact Scale is a participation level test, so you can really get an idea of how the individual feels about their limitations and what they are able to do, and track their confidence in their ability to interact with their environment through that way. The Mini Best test is a higher level balance test that really gets at a lot of the different areas of balance and is a great way to gather information. And the bottom 2 we've already talked about when we talked about motor selective testing and spasticity. And then I would be remiss if I didn't talk about some of these other areas that can be impaired in someone following a stroke, but maybe aren't what we focus most on in physical therapy. We do talk about musculoskeletal pain in physical therapy, but often in stroke it's not the highlight. But I want to direct you to that hemiparetic shoulder. If we're in a setting where there's an occupational therapist, they tend to kind of take ownership of that shoulder, but we all are responsible for making sure that that shoulder is safe. So if the patient has low tone, we need to be making sure that that shoulder is not subluxing and causing them pain. Whereas if they have high tone or hypertonia, we need to make sure that they're not getting pain from some impingement in there. So being aware of what's happening in that shoulder, even when you have an occupational therapist in your setting, is really important. Positioning, incontinence, how they're resting in bed, how they're resting in their chair can make a big impact on whether or not their skin integrity remains intact. Edema is pretty common in any dependent limb, especially the hand and the foot. So working with your nurses and your occupational therapists on making sure that there's not too much edema in that hand. Depression, DVTs, bowel and bladder issues, and sexual issues are all common after stroke. And so again, while they're not necessarily what we focus on in physical therapy, it is all of our responsibility to be keeping an eye on these things and doing what the patient needs. So either have the conversation with the patient or refer them out to someone who can help them with those issues. Okay, we're going to transition a little bit into interventions. This is what we want to know. Now we have a patient here with stroke. What do we do? And so I want to reintroduce you to the big word neuroplasticity. Research currently recognizes the presence and the impact of neuroplasticity in motor control theory. And so it's not a new article, but these are the highlights of the 10 principles of neuroplasticity. I'm guessing you've heard them before, they should be familiar to you. But we're going to talk about a few of these today, specifically specificity, repetition and intensity, salience, and time. I do want to say a little bit of use it or lose it and use it and improve it. If someone has an impairment and they're choosing to not use that limb, it's not going to get better. Whereas if they're using it, it can get better. So I always tell my patients, I know it's hard, I know it feels like it's not working, but if you want it to get better, you have to use it. And so making sure we're educating our patients on the fact that if they use the body part that they want to get better, that's the only way it's going to improve. So as we come to picking our interventions, I really want you to remember the basics. The neuroplasticity principles that we just talked about, focusing on intensity, repetition, and specificity. They need to be working really hard, doing a lot of reps on a meaningful task in order to drive that neuroplasticity. We've already talked about use it or lose it. Salience means that what they're doing really needs to matter to them. So the task that we're giving them needs to feel important to what they're doing. If you're having them move cones, for example, there's nothing wrong with moving cones, especially if you're having them reach or do something that's challenging, but they need to know why they're doing that. If it's a rote task, it's not going to have the same type of meaning to them as if they realize that moving the cones is the same as, say, putting away the dishes, right? It's a meaningful task for something that they want to get better at, will drive neuroplasticity. Time matters in that the closer we are to the time of the stroke, the easier that neuroplasticity is. So the best thing that we can do there is capitalize on their time there and really make them work hard. Whatever we're doing, we have to keep them safe. So getting a second person to help, using lifts, finding a wheelchair follower, keeping those gait belts handy. Safety is key, but we have to get them moving. Mobility and teaching them how to start doing those tasks again is what really matters to give them the functional independence. What do they need to be able to do? Get out of bed, walk across the room, go to the bathroom, climb stairs. Those are the interventions that are going to get them able to do their own ADLs and give them their life back. So if you don't know where else to start with your interventions, start with functional mobility and then make them work hard at it. So this line down here at the bottom is my favorite. Make them work hard doing things that matter to them. If it matters to them and they work really hard while they're doing it, that drives neuroplasticity. We have to think a little bit about motor learning. So how we practice something or how we go about doing a task matters. So generally speaking, they say that if we practice a task in a randomized order, it's generally better than doing the same thing over and over again, moving to the next step and doing that thing over and over again. But we have to keep in mind the individual's cognition. If their cognition is impaired, we probably can't have them practicing things in a random order because it's going to be too challenging. So adapting your practice schedule to meet their needs. Go down to talking about feedback. How much we say and when we say it also matters. As a general rule, less is more. Sometimes we have to start with quite a bit of feedback to get them to perform the task correctly or do what we're looking for, and then fade back that feedback as we go. Sometimes people do really well with verbal feedback versus tactile cues. Really getting a handle on what works for your patient and adapting your approach is the most useful part. I want you to think a little bit about external focus when possible. So that might be as simple as your patient's walking down the hall and every time they take a step, they drag their foot. Instead of telling them, pick up your foot when you take a step, try an external focus like, I don't want to hear your foot on the floor when you take that step. Those external cues are often more useful in getting the patient to make the necessary changes because they're not focused on their body, but focused on the movement that needs to occur. So this really is just all about getting you to recognize that no practice session is going to be universal to everybody. How they practice, what you say to them, and how often you say it needs to be adjusted to what the patient responds to, how's their cognition, how's their attention to task, and adapting it accordingly. So to kind of wrap things up as we talk about intervention overview, is to avoid focus on normal movement. Literature is starting to tell us that it's more important that people move and that they work hard while they're moving rather than to move normally. It doesn't have to be normal movement, they just need to get going. So focus on providing an opportunity to solve a movement problem. I want you to get across the room. Let them get across the room, even if it is not the most perfect walk you've ever seen. You want them to get from here to there and their brain to figure out how to solve the movement problem to get there. That's what drives neuroplasticity and promotes recovery. And again, if you don't know where to start simple. Start with bed mobility, helping them get out of bed. That's pretty important. People want to get out of bed and use a commode or a real bathroom. So start with bed mobility and transfers. Then start moving into the walking and all of the other pieces that matter. If you don't know where to start there. And then one of my favorite things about physical therapy is the ability to get creative with what we do. Adapt our environment and adapt the task to meet our patients' needs. If they're a farmer, if they work in a factory, whatever it is that they do, using our tasks to be meaningful to them. And we can do that simply by using different surfaces, changing the lighting, changing distractions. Use what's around you, use whatever's in your clinic to adapt what you're doing to be meaningful to them and to find just the right amount of challenge. If it's too hard, they're going to get frustrated. If it's too easy, there's no neuroplasticity. So adapt what's around them to make the task just right. I want to talk for a minute about another clinical practice guideline produced by the American Physical Therapy Association's Neurologic Academy. And the goal of this one was to tell us what works best to improve locomotor function following any number of these diagnoses that includes chronic stroke. And so what this tells us is that there are a number of things we should and shouldn't do according to the literature to improve locomotor function. And I kind of organized it in a stoplight format. What clinicians should do, according to the literature, this is the highest evidence that's available out there, is moderate to high intensity gait training or gait training with the use of virtual reality. Now remember, I talked about specificity. This clinical practice guideline is talking about improving walking. You want to improve walking, we need to work on walking, and they need to work hard at doing it. So those two shouldn't be too surprising. They say to improve walking, we should also think about strength training and circuit training, or even recumbent stepping, as long as they're working hard, right? High 1 rep max, high heart rate, if we want to drive that neuroplasticity. We can also use balance training with virtual reality. What it says that we shouldn't necessarily focus on is static and dynamic balance, or those pre-gait tasks that we've all done for a long time, trying to break down that gait cycle into little bitty pieces and have them practice those. They're saying that's not as beneficial as doing the whole task really hard, even if it doesn't look good. They're also saying that body weight support treadmill training that focuses on the actual kinematics isn't as useful, nor is robot-assisted gait training, because they're really focusing on the kinematics and the patient potentially won't have to work as hard as the moderate to high intensity gait training. So I want a little caveat there is it doesn't mean we can't do all of these other things if we're looking to improve something else. This clinical practice guideline was specifically about improving locomotor function. So if you want to improve balance, work on balance. How to define that moderate to high intensity training, because that's new to some of us. It really is talking about getting that heart rate up, either a max heart rate or an RPE, and keeping that intensity high. You can calculate it using their heart rate max. There is actually a calculator online to help you determine heart rate max based on their age. But I do want you to keep in mind that if they're using beta blockers, that heart rate isn't going to change in the same way, and you cannot use heart rate max, you need to use RPE. But really, if you're doing that, you need to have a wearable heart rate monitor so you continuously monitor their heart rate, make sure they're in a safe zone. Make sure you're talking to their physician if you're doing something like this to make sure that they're safe to train at that higher heart rate. But one little takeaway I want you to think about is that we cannot substitute duration for intensity. So putting them on the treadmill longer and keeping that heart rate lower is not the same thing. Driving neuroplasticity requires the intensity. And a third clinical practice guideline that we're going to talk about briefly was just recently published in 2021, again from the same group, talking about the use of AFOs or functional e-stim in individuals after stroke. And so again, I broke all of their action statements down into a number of summaries in kind of that stoplight format. But really what we're looking at here is for either an acute or a chronic stroke, so that subacute setting fits in there nicely. If we're wanting to improve quality of life, gait speed, dynamic balance, or in this case, other mobility really needs transfers and balance and all those other things that we do, we should be using either an AFO or FES for these individuals. That's what the research tells us. So I know sometimes there's some hesitancy to put an AFO on individuals, but the literature is telling us it can do a lot of great things. In the chronic phase, they're telling us that we should use an AFO or FES, whereas we're in this acute phase often here. They're saying we may if the goal is to improve walking endurance. So if you want your patient to move further, you might consider using an AFO because they won't fatigue quite as quickly if we're controlling that ankle a little bit better. If the goal is to improve gait kinematics, so really we're just worrying about getting that foot drop up, then you might think about using an AFO. That makes sense. If we're talking about improving strength and muscle activation, we should be using FES. We're using e-stim to turn on that muscle, and so it should make sense that using FES in theory can improve muscle activation. Now what they're telling us is that if we're going to use an AFO, it needs to be a decreased stiffness AFO. What I like to say is bendy. That's a very technical term. The AFO needs to be bendy because if the AFO can bend, that means they can actually move their ankle in a more normal way. It still keeps their foot from dragging, but the bendiness of the AFO allows that muscle to turn on a little bit more normally. And so you can improve strength and muscle activation with an FES or a bendy AFO. And then finally, what the literature tells us is that AFOs nor FES work to improve tone and spasticity. You can use it to help keep the ankle in a better position, but you're not going to make tone or spasticity better by using either of those interventions. My final point about that clinical practice guideline that I always like to make is using that AFO to improve gait speed, improve walking endurance, can also help you to get them walking longer and a higher intensity. So you can use that to really drive home that higher intensity gait training that we just talked about in the previous clinical practice guideline. And then finally, I want to talk about strengthening interventions. That's what we as physical therapists do, is build strength. And sometimes when we just really don't know what to do, it's easy to just do the same strengthening program for everybody, right? Let's hit all of the muscle groups and let's just build up strength everywhere. That's great if the patient is generally deconditioned. But if they are moving pretty well or kind of young and you can really tell that they don't need generalized strengthening, these are the muscle groups that are very commonly affected by stroke. Those hip extensors, hip abductors, and plantar flexors, those muscle groups can truly impact the way someone is able to walk and walk in a semi-normal fashion. And so be very strategic about which position you're choosing to put them in to put those muscles in a position to optimally strengthen them. Laying down supine or basic standing exercises isn't necessarily the ideal position for everyone, so maybe you need to get them into side lying or tall kneeling and have them walk on their knees to isolate some of these muscle groups and start to strengthen very strategically in a targeted manner as opposed to a blanket approach. And then finally, we'll talk about discharge planning, which even though we're talking about it at the end, starts at the beginning. The minute they come to our facility, we need to start thinking about where is the next step for these individuals. And so there's really two options. They can go home or they can go not home, right? If we want them to go home, they need to be demonstrating no safety issues pretty much, and they need to be at an independent level with their mobility. If they're not independent or they're not safe, then they probably shouldn't go home. So we need to be looking at the laundry list of other places that they can go and also using that to direct our interventions. Is it safety we need to be looking at, or is it their functional mobility? Sometimes we just don't know where the next place to go is. And so the American Heart Association has this wonderful resource that compares all the different levels of care, what the purpose of the facility is, what kind of therapy and care that they will get there. So comparing inpatient rehab to skilled nursing, or even some of the outpatient options like traditional outpatient or a day program or even home health, figuring out what the next appropriate level of care is that meets all of your patients' needs, depending on are they independent and are they safe, is the most important. And then I want you to think about this discharge planning pathway for a moment. Just because they might be in inpatient rehab or they might be in skilled nursing doesn't mean the next automatic step is home or outpatient therapy. They can go anywhere through this algorithm at any time. So they can go to skilled nursing and then do enough better that they now qualify for inpatient rehab, or vice versa, before they go home. So keeping in mind that throughout the episode of care, we should be constantly reevaluating for how they're doing, what they qualify for, and what's best going to meet their needs. Should they go home, or should they go to another facility to keep them safe and continue their progress? Okay, now that we've talked a little bit about the pieces of an assessment and a treatment, we're going to see an example of a patient interaction where the therapist is working with a patient in a post-acute setting, working through bed mobility, getting out of bed, doing some of those initial transfers. We'll take a look at some of the different strategies for gait training and even how to incorporate stair training into your sessions. Okay, Andrea, now that we've gotten through the question part of the assessment, I'm going to go ahead and just do some tests to see how you're feeling and how your body's moving, okay? Okay, so I'm going to go ahead and pull down the covers. Okay. And then the first thing I'm going to do is test the feeling in your hands. So I'm going to have you keep your eyes open. I'm going to touch you on that left side and see how it feels, and then I'll have you close your eyes, and we'll do it on the right side. So this is what it's going to feel like. Okay, so I want you to go ahead and close your eyes. Tell me where I'm touching.
Down there.
Okay, you can point to it.
Down there.
Good. And did it feel the same as the other side?
No.
No. What did it feel, more or less?
Less.
Less? Okay. I'm going to do one more on your hand. You can point to it.
This?
You felt it on your thumb?
Yeah.
Okay. And so it felt the same or different?
Less.
Okay. I'm going to do one more up on your forearm, okay? Did you feel that?
No.
No. Okay. So the right arm just doesn't have as good a feeling as the left arm. Okay. I'm going to do that same test now down on your feet.
Okay.
Okay. So I'm going to pull your pant leg up a little bit. And then I'm going to test your left foot. I want you to keep your eyes open. This is what it's going to feel like.
Okay.
Okay. Now I'm going to do that on this right side. Okay. I want you to point or tell me where it's at, and then tell me if it feels the same or different. Okay. Okay. Go ahead and close your eyes. You can point to or tell me where you felt that. Okay. Was it the same or different?
Less.
Less? Okay. Point to it. Okay. Same or different?
Different.
Okay. That's hard to get your foot over there. Okay. Same or different?
Different.
Okay. Did you feel that one?
No.
No? Okay. And then one more. Okay. You can go ahead and open your eyes. Seems like your foot has pretty good feeling. It's just not quite as much as you come up the leg. No. So the next thing that I'm going to do is see how you do just moving your arms and legs. Okay. So I want you to raise your arms up over the top of your head. Go ahead and do the left one first. Perfect. Come on back down. Now can you move that right one up? Okay. And you can help it with the left arm if you need to. Good. Okay, go ahead and bring that back down. I'm going to help you with that just a little bit. Go ahead and bring that back up. Now, pull your hand to your mouth. Good. Now push me away. Right down toward me. Good. All right. Let's see if I can open that up a little bit. It's kind of tight too, huh?
Yep.
Okay. Now I want to do the same thing to your legs. Go ahead and bring your left knee just kind of up towards your chest and bring it back down. Can you do that same thing with this right leg? Good. Okay. All right. So it's got some movement in it. Excellent. Okay, so we're gonna go ahead and test the strength in your legs, and then I'm gonna see how you do rolling around in the bed a little bit, okay? So the first thing we're gonna do, I'm gonna have you bend this knee. Just kind of pull it up. Good. Now I'm gonna pull on it. I want you to hold it right there. Good. I want you to push your knee out that way. Good. Now push back in this way. Good. And then flatten it out down to the bed. Push hard. Good. All right. Now I'm gonna have you bend this knee as best you can. Good. Now just hold it right there. Push out toward me. Good. And then relax. Hold it right there. I'm gonna pull. Hold it still. There you go. Now push it back in that direction. Relax. And then go ahead and straighten it out back down to the bed. Good. Now, I'd like you to go ahead and lift that leg up off the bed a little bit. Okay, bring it back down. Keep your knee straight and lift it up a bit.
Oh.
There you go. And then keep this leg. Good, okay. All right. We all know it's easier for a patient to transfer toward their stronger side. Whether it's rolling over in bed or getting up to a chair, moving toward one's stronger side is typically easier and sets them up for success early on. However, it's really important in the real world for a patient to be able to move in any direction. So while the first time you might go toward their stronger side to see how they're moving, it's important that you train moving in both directions. Okay, we're gonna go ahead and do a little bit of, I'm gonna flatten out the bed. We're gonna move around a little bit. Okay. And so what we're gonna do once I get this bed a little bit flatter, I'm gonna have you bring your knees up. We're gonna see if you can lift your hips up off the bed.
Okay.
And we're gonna roll left, and we're gonna roll right.
Okay.
Okay. Okay. So the first thing I want you to do is just bring your knees up underneath you, or your feet up underneath you. Okay, set them down. Now I want you to try to lift your hips up off the bed. That's pretty good. Good. All right, you got pretty good strength. Go ahead and lower your legs back down to the bed. I'm gonna have you roll straight to your left side, so reach over toward the railing with this arm. Good. Okay, good. And then go ahead and come onto your back. Good. And then I'm gonna have you roll to your right side. Good. All right. And then we'll go ahead and get up. Okay. Okay, Andrea, the next thing we're gonna do is we're gonna go ahead and stand up. I just want to see how you do in taking weight on both of your legs.
Okay.
And then after that, we'll go ahead and come over and sit in this wheelchair behind you, okay? All right, so whenever you're ready, go ahead and stand up. Good. Okay. Now I want you to just take a little weight on this right leg. Okay. Good. All right. All right, so I'm going to go ahead and step out of your way, and I'm going to have you come over and sit in this chair behind me, okay? All right. And back all the way up. Good. And then I want you to reach back and have a seat. Okay. And now we'll go over and take a walk. Okay. We've already talked about the importance of salience and choosing interventions that are meaningful to your patient. Walking is very meaningful to almost every patient, so it's a great intervention that we can progress over time to find the appropriate level of challenge. You can start by walking with no assisted device and no device to help control the foot or ankle. Over time, we can progressively add devices, we can change their assisted device, we can add an AFO or any sort of a strap that helps to control the mechanics of the leg to decrease the risk of foot drop or injury. We can also change the environment in which they're walking. We can make them walk faster or slower, add obstacles, change the lighting, or even change the surface that they're walking on to make the task an appropriate challenge. It's important to pay attention to a hemiparetic shoulder. Regardless of whether it has low tone, is subluxed, is at risk for subluxing, or even has high tone and some pain. We should always attend to the shoulder while the patient is mobilizing. We can do this by either managing it with your hands or selecting an appropriate brace that keeps the shoulder in a protected position. Ideally, they're still allowed to move their arm while they're wearing the brace, but if we select a brace that immobilizes the arm and the shoulder, we should never leave this on all the time. So I want to have you go for a little bit of a walk down the hall, and I'm going to have you do it without any sort of an ankle brace so I can see what your knee and your ankle are doing while you're walking. So we'll see how that goes. I'll let you do it with a cane so you feel a little bit more secure.
Yes.
Okay, go ahead and stand all the way up. All right. I'll come around behind you. You don't have to go quickly. I just want to see how it looks. A little harder to clear your toes.
Yep.
Mm-hmm. And the knee kind of likes to stay bent for you, doesn't it?
Yep.
Okay. Good. I think this AFO works well,
Yeah.
helping you clear your toes.
Yep.
Yep. Okay, we'll have a seat here. Okay, we're gonna go for one more walk. I wanna use this strap as a tool to help your knee bend and straighten a little bit more smoothly when you're walking, and it will also help kind of lift your toes up off the ground because they don't want to.
Yeah.
So we're gonna go for one more walk.
Okay.
Okay, get a feel for it. It feels a little different.
Whoa.
Kind of makes those ankles and toes do something a little different, doesn't it?
Huh.
Huh. What do you think?
I like it.
I like it. Make a U-turn, whichever way you want. It's a very cool little gadget.
Yeah.
Okay, maybe not such a long step on that right side if you can. There you go. Okay, and I'll let you have a seat here. Okay. When working with a patient who's lower level or is having a harder time moving, you can still do gait training as an intervention. Just make sure you keep safety in mind first. Gather more people, keep the wheelchair close behind, or use whatever you have in your facility to help keep them safe. Some facilities have a track in the ceiling, some sort of a harness system, anything that you can use to keep them upright. One thing that you could use is even a dependent lift type system like a Hoyer and a modified harness that goes on like pants or shorts, and you can get a patient up with equipment that's in almost every facility to get them started taking steps. Don't let a patient who's having a harder time moving not gait train just because it's a little more of a challenge. Use any of the equipment and any of the people around you to get them up and get moving. Stairs are a great way to challenge your patient functionally when they're starting to do well on tasks like walking on level surfaces. So the first step is usually having them climb stairs with their weaker leg first, which is what we teach. But this can easily be progressed to increase the challenge by having them alternate steps, so one step over the other, and making the weaker leg do the work of ascent every other step, and then the work of descent every other step. You can make it even harder by then having the weaker leg control the ascent every step and the descent every step. We're gonna go ahead and practice stairs next. So I'll have you walk on over to the stairs, and once we get there, I'll just have you put your cane up against the wall there, out of the way. Okay, so I'm gonna have you go up one foot over the other. So right foot can go first, and then the left, and just keep on going. One more. Good.